You are listening to the Loop Podcast, a project in plastic surgery innovation.
Hello, everyone, and welcome back to the Loop Podcast. In this episode, we will be discussing hand tendons. This is a daunting task since this is such a broad topic, but it's very high yield, so we hope you find this handy. You see what I did over there?
Yes.
Hand can be very confusing, so I urge everyone to watch the corresponding YouTube video for complimentary visuals. We will be featuring two outstanding illustrators, Mike Natter, my friend and legend, and also on Instagram, Surgical Anatomy. Their handle is @surgicalanatomy. They have really good illustrations and good pictures for anatomy for hands, so I recommend you follow them on Instagram. Today, I'm joined with Dr. Sanam Zahedi. Thanks, God. How are you doing?
Hi, how are you?
Want to fire it up?
Let's do it. Let's start with the extensor tendons and their corresponding compartments as they cross the wrist. There are 6 compartments. The first one is the extensor pollicis brevis and abductor pollicis longus. The second one is the extensor carpi radialis brevis and extensor carpi radialis longus. The third compartment is the extensor pollicis longus. Between compartments 2 and 3 is Lister's tubercle, which is clinically relevant because sometimes Lister's tubercle can cause tendinitis of the EPL. And with distal radius fractures, it can actually cause a rupture of the EPL. In the fourth compartment, there's the extensor digiti communis and extensor indicis proprius, or for short EIP. EIP is ulnar to EDC of the index finger, and EDC often has an absent EDC tendon to the small finger. But because of the juncturae that are there, it allows you to extend the small finger. In the fifth compartment, there's the extensor digiti minimi, and in the sixth compartment, there's the extensor carpi ulnaris.
Great. Now let's focus on specific muscles and their pertinent anatomy, starting with the extrinsic extensors. The extensor muscles are innervated by the radial nerve. The radial nerve also innervates the brachioradialis, even though it is a flexor muscle in pronation. As a result, radial nerve palsy will result in a wrist drop. This is also known as Saturday night palsy. Sanam, do you know why this is called Saturday night palsy?
No, but I am sure you're going to tell us all.
Yes, after a bender on Saturday night, when you pass out on the park bench and your arm is dangling on the park bench, you have opposition of your humerus to the park bench impinging the radial nerve. You wake up with basically wrist drop. So there you go.
Good to know. Now, you want to tell everyone how many times you've had that?
No, not that many times. How many times have you?
None. Go ahead.
Not that
Next
much.
topic.
Do you want to talk about muscle origin and insertions, starting with the most proximal origins?
Sure. The extensor carpi radialis longus and brachioradialis originate from the supracondyle ridge of the distal humerus. Then moving down, the superficial extensions all have a common origin on an even more distal part of the humerus and lateral epicondyle. The superficial extensor muscles include, there's 4 of them: extensor carpi radialis brevis, extensor digiti communis, extensor digiti minimi, and extensor carpi ulnaris. Moving down along the arm, we have the deep extensor muscles. That includes, again, another 4, the abductor pollicis longus, the extensor pollicis brevis, the extensor pollicis longus, and the extensor indicis proprius. Of note, the EIP has the most distal muscle belly and can frequently be used to uniquely identify this tendon, and they love to pimp this question. Now, Brian, what are the wrist extensors and flexor muscles?
So the wrist extensors include the extensor carpi radialis longus, which inserts at the base of the second metacarpal. The extensor carpi radialis brevis inserts on the base of the third metacarpal. And the extensor carpi ulnaris inserts at the base of the fifth metacarpal. For finger extensors, the EDC goes to the index, middle, ring, and small finger. The EIP goes to the index finger only. The EDM goes to the small finger only. The fact that the EIP and the EDM give independent extensorability to the index finger and small finger, respectively, is why you can make the Go Longhorns sign, but you wouldn't know anything about that as a Gator fan.
100%. We don't use that sign
clap.
at all.
You just do the clap. Yeah, when it comes to the thumb, there's more than just flexion and extension. Sanam, do you know what else the thumb does? And do you want to go over what muscles are responsible for this?
For sure. The first one is the extensor pollicis longus. It inserts to the DIP and it extends the DIP joint, and it also dorsally abducts the PIP and MCP joints. Then there's the extensor pollicis brevis, or EPB. That inserts on the proximal phalanx, and its action is to extend the MP joint. Then you have the abductor pollicis longus, or APL. It inserts first on the metacarpal phalangeal joint and then radially abducts the metacarpal and deviates the wrist. Now let's focus on extensor tendon zones, which are important during extensor tendon injury. So starting with the thumb zones, the thumb has 5 zones. If you're around the DIP area, you're in the first zone. The second zone is at your proximal phalanx. The third zone is at your metacarpal phalangeal joint. Your fourth zone is at the metacarpal, and the fifth one is at the CMC. Now, Brian, what are the other zones of injury for the rest of the hand and upper extremity?
Sure, there are 8 extensor tendon injury classifications. So starting with zone 1, that's at the DIP joint, and that can result from a disruption of the terminal extensor tendon, distal to or at the DIP joint, and that frequently results in a mallet finger. Zone 2 is at the middle phalanx, so you can have disruption of the tendon over the middle phalanx or proximal phalanx of the thumb. Zone 3 is at the PIP joint, and this often results in an injury to the central slip or the MCP joint of the thumb, like you said. And this can affect the EPL and EPB and result in boutonniere deformity. Zone 4 is an injury to the proximal phalanx, and that can be an injury to the EPL and EPB. Zone 5 is at the MCP joint. This is typically seen in a fight bite or a sagittal band rupture. Zone 6 is at the metacarpals, and at this zone, nerve and vessel injury are likely. Zone 7 is at the carpal bones, and Zone 8 is at the proximal wrist. Now, let's dig deeper and talk about Zone 1 for a little bit more, because this is a pretty high-yield topic. This usually happens when playing sports and there's a direct blow or axial force to the fingertip, whether it's a basketball or football or whatever. The forceful flexion damage the extensor tendon where it's attached to the proximal portion of the distal phalanx. So on exam, you'll find an extensor lag or a fixed flexion deformity, and that's due to unopposed flexor pull. For a type 1 or closed mallet finger injury, you can treat this acutely by just splinting the patient in extension for 6 to 8 weeks. You may actually want to put the patient in slight hyperextension. And the point of this is that you're counting on scarring to take place, effectively treat the patient without surgery. The patient cannot tolerate splinting. They cannot wear a splint to work, for example, like a surgeon. You can consider K-wire fixation. The patient hasn't been treated for 4 weeks. This is referred to as a chronic mallet finger, at which point splinting can be tried. However, if it fails, the patient's at risk for a swan neck deformity. So options at that point equate to 3 things. The first thing you can do is a Fowler tenotomy, where you perform a tenotomy over the central slip and allow for the extensor tendon mechanism to slide proximally to decrease the extensor lag. Second thing you can do is an oblique retinacular ligament reconstruction, where you link the volar flexor sheath to the lateral terminal tendon, and this provides a mechanism for automatic DIP extension and active PIP extension. The third thing you could do is something called dermatotenodesis, where you excise the scar and skin entirely and repair it with suture. Moving on to type 2 or type 3 mallet injuries, also known as an open mallet injury, you want to make sure you debride and do a tendon repair in the OR. For type 4 mallet injuries or a mallet fracture, the small articular surface can be splinted. Large surface fracture with volar subluxation of the DIP can be operatively fixed. Keep in mind, for children, this injury is known as a Seymour fracture, and the fracture goes through the physioflate, so an open reduction internal fixation is indicated in this surgery.
Is it considered an open fracture, Brian?
Yeah. Oh yeah, that's on the test. High yield stuff. All right. You want to shift gears now, Sanam? Do you want to get into the nitty gritty and talk about complex extensor mechanism?
Sure. The extensor digidae communis is the main extrinsic tendon that allows for finger extension. It inserts on the sagittal band system to allow for the MP joint to extend. The sagittal bands originate in the volar plate and anchor the extensor mechanism of the EDC in a central position at the MP joint. Injury here can lead to subluxation of the EDC and therefore compromise extension of the fingers. So basically, when you have injury to the sagittal bands, you can end up having weakness in terms of extending your fingers if this were the case. Then the EDC trifurcates proximal to the PIP joint, with the central component becoming the central slip and the lateral components coalesce over the middle phalanx and continue distally to become the central tendon. The lateral bands are maintained in position by the triangular ligament, which prevents volar subluxation during PIP flexion. And an injury to this would result in a boutonniere deformity. So with a boutonniere deformity, you have flexion of your PIPJ and extension of your DIPJ. You're not able to extend your PIPJ. And that makes sense, right? Because if your lateral bands are causing you to have volar subluxation of your tendons, then you're not going to be able to have as good of an extensor tendon mechanism for your PIPJ. Also, the transverse retinacular ligament is there to prevent dorsal subluxation of the lateral bands during extension. An injury to this can result in a swan neck deformity. So with a swan neck deformity, you're going to have flexion of the DIP and hyperextension of the PIPJ. And then you have the oblique retinacular ligament of Landsmeer, which originates from the flexor sheath at the volar portion of the PIP and inserts on the dorsal terminal tendon. It tightens with extension of the PIP and extends DIP during PIP extension. It basically pulls the proximal and distal interphalangeal joint extensions together. So if this becomes fibrotic, it can also lead to near deformity. Again, you'll see the PIPJ flexion and the DIPJ hyperextension. Now that we know the different extensor compartments and the extensor mechanism, Brian, can you tell us what can happen within each compartment?
Yeah, sure. So tenosynovitis is inflammation that occurs in the tendon sheath in the extensor compartment. When this happens, it can lead to pain on palpation as well as pain at rest. When it happens in the first compartment, it's called decurvens. This is characterized by pain and tenderness. It's usually 1 to 2 centimeters proximal over the radial styloid, and it's aggravated by movement of the thumb and a positive Finkelstein test, which is usually when you have your thumb in your fist and you ask the patient to ulnarly move their hand. Clinically, patients will say that it's exacerbated when they start moving it in activities that are effectively doing the same thing as a Finkelstein test. Sometimes it's mothers picking up their child. Typically, initial treatment consists of splinting the hand in extension with the thumb abducted with steroid injections. However, if you have an anatomic variation, which is fairly common, steroids will not fix the underlying problem since there's an anatomic variation. The variation is a longitudinal septum in the first dorsal compartment that separates the EPB from APL. If steroids fail, it's possible that this variant exists and operative release may be the next best step. This is a very common in-service question. The most common complication of operative release, however, is injury to the radial sensory nerve. So be careful. That's another testable pearl there. Sanam, what is intersection syndrome?
So that's when you have tenosynovitis of the second dorsal compartment where the first dorsal compartment crosses over it. So if you have inflammation and entrapment of the extensor carpi radialis brevis and longus, where the abductor pollicis longus and the extensor pollicis brevis are trying to cross over it. This is common in rowers and weightlifters. Basically, think anyone with a repetitive wrist extension. Signs and symptoms include swelling about a few centimeters proximal to Lister's tubercle. So that's more proximal than decurvens. And you have pain and crepitus with palpation of the APL and EPB. This is treated with NSAID, splint and extension, and steroid injections. Rarely surgery for decompression is needed, except for reoccurring cases. Brian, what's going on the third compartment?
So third compartment is EPL, extensor pollicis longus. So if you have EPL tendonitis, you may just present with pain and movement of the thumb at Lister's tubercle. If you take a look at the cross-section of the wrist and look at where the extensor compartments are and where the tendons lie in relation to Lister's tubercle, you'll notice the compartment that the EPL is in, the third compartment, is just ulnar to Lister's tubercle, and it's intimately related to that structure. If you have tendonitis only, the treatment would be to operate to prevent rupture. The goal of the operation would be to transpose the EPL radial to the tubercle to decrease the risk of rupture. EPL rupture can be seen in a distal radius fracture or in patients that have rheumatoid arthritis. On exam, you would see an absence of retropulsion and not being able to lift the thumb off the table. Again, EPL lifting the thumb off the table. If this is chronic, say months or years, and the muscle is degenerated, the best reconstruction would be a tendon transfer. And the tendon transfer of choice would be an EIP to EPL transfer. In the sixth and most ulnar compartment, there's the ECU muscle. ECU tendonitis may be present with wrist pain, usually after a twisting motion. It may cause nocturnal awakening. Treatment is NSAIDs, splinting, and steroid injections. Let's shift gears here now and talk briefly about tendon transfers. Sanam, you want to go for it?
Not really. I'm just kidding.
Yeah, I didn't
It's
want to
my
do
least.
that.
So the tendon transfers are utilized when reinnervation cannot be achieved. Reinnervations of muscles should ideally be completed within about 12 to 18 months after injury to allow for recovery. So if you miss the window of opportunity to reinnervate them, then tendon transfer is indicated for dynamic motion. The goal here is to use an expendable donor tendon to provide a missing function. This donor tendon should have adequate strength, range of motion, and desired function, and it ideally should have synergistic action and allow tenodesis to facilitate re-education. So let's go over some examples. If someone with a long-standing radial nerve palsy from a humerus fracture needed wrist extension back, then a good option would be doing a median nerve innervated pronator teres to extensor carpi radialis brevis. This muscle is strong, it gives adequate power and excursion to provide that wrist extension. And then if you have flexor carpi ulnaris, could also work because it's strong enough, but it's not synergistic since it works as a wrist flexor instead of an extensor. So as opposed to using the flexor carpi ulnaris, if you use the flexor digitorum profundus, it's an important finger flexor. So it's not a good idea to use that as a replacement for your extensor. And then brachioradialis is a radial nerve innervated muscle. So that muscle is atrophic and paralyzed in general. So you're not going to be able to use it for this example anyways. All right, so that's all we'll cover for extensor tendons. Hand is a difficult topic because there are endless things that can be asked. But generally, if you know the anatomy, a lot of the anxiety can be cut. Brian, do you want to talk about flexor tendons now?
Yeah, I love flexing. All right, we're halfway there. Let's keep moving here. FDP is in the deepest compartment of the forearm, as is flexor pollicis longus. It originates at the volar and medial aspects of the proximal 3/4 of the ulna and the interosseous membrane. The ulnar artery is the main blood supply to this muscle. The ring finger and small finger is innervated by the ulnar nerve, whereas the index finger and the middle finger is innervated by the anterior interosseous nerve, which is the branch of the median nerve. The FDS has two heads of origin. The ulnar head has an anterior aspect that is on the medial epicondyle, the ulnar collateral ligament, medial aspect of the coronoid process and proximal ulna. And then the radial head is at the proximal radius, immediately distal to insertion of the supinator muscle and deep to the pronator teres. In the mid forearm, it divides and it gives rise to the superficial and deep tendons. The superficial consists of the ring finger and the middle finger, and the deep consists of the index finger and the small finger. The vascular supply is given by the radial ulnar artery, and the motor is given by the median nerve, and it's loosely adherent to the deep surface of the FDS. The FDS divides into two slips encircling FDP tendon, first volar, then radial and ulnar, and then finally dorsal. The two portions reunite at Camper's chiasm and redivided before inserting onto the middle volar aspect of the middle phalanx. Sanam, do you want to go over the all-important pulley system?
Definitely. Now this is a part I can go with. So the annular pulleys serve to prevent tendon bowstringing during digital flexion. The innermost layer secretes hyaluronic acid to facilitate that gliding motion. The middle layer is rich in collagen and resists palmar translation of the tendons. The outer areolar layer supports blood supply to the tendons. So now let's think the numbering and the naming of these pulleys. The odd number pulleys correspond to joint spaces, and you start proximal and work your way distal. So for example, A1 is at the MCP joint, A3 is at the PIP, and A5 is at the DIP. And then in between them, at the proximal phalanx, you have the A2, and at the middle phalanx, you have the A4 pulley. These pulleys arise from the volar plate at their respective joints. A2 and A4 pulleys are the biggest and most important and attach directly to the bone. A2 and A4 are the narrowest and most constricting to the flexor tendons, so thereby they compress the repaired tendon secondary to post-op edema. Clinical pearl. The rupture of the A2 pulley, like let's say from rock climbing, is treated with rest, ice, NSAIDs, and external splinting. Brian, what's the blood supply to these pulley structures?
The common digital artery gives transverse branches to supply the vinculum longum and the vincular system, giving the outer areolar tissue direct line of blood flow for the tendons and for the pulleys. In zone 2, there's dual blood supply, and it's worth noting. The first blood supply is the parietal peritoneum, allowing for passive nutrient delivery and also waste removal from the flexor tendon and the flexor tendon sheath, and this is through diffusion. The second blood supply in zone 2 is direct arterial blood flow from the vincular system, osseous bony insertions, and reflected vessels from the palm.
Just like for the extensors, there are different zones of injury. There are zones of injury for the flexor side. Brian, can you tell us more about this?
Sure. So starting from zone 1, this is going to be distal to the FDS insertion on the midpoint of the middle phalanx. Zone 2, also known as no man's land, is FDS insertion, which is the midpoint of the middle phalanx to the level of the A1 pulley, distal to the palmar crease. Zone 3 is the proximal aspect of A1 pulley, which is again distal palmar crease, to the origin of the lumbricals from the FDP tendons, which is the distal edge of the transverse carpal ligament. Zone 4 is the carpal tunnel, Zone 5 is the proximal aspect of transverse carpal ligament to the musculotendinous junction. For partial lacerations, studies have shown that there's no difference in healing between 25% laceration and 50% laceration repair. However, 75% laceration resulted in significantly lower quality healing without repair. So this kind of led to the 50% rule. And over time, this was studied. And actually, one of the first studies ever evaluating this was Chow and Yu in 1984, when they assessed chicken tendon repairs. And I guess they were doing research on chicken fingers. Since then, there's been several studies. There's one worth noting in 2015. There was a paper called The 50% Rule in Arthroscopic and Orthopedic Surgery, where they used biometric objective data to evaluate the tensile strength of tendon repairs. And the long and short of it is that the strength of the tendon pretty much plateaus at about 50%. But once you go beyond 50%, then the strength of the tendon significantly drops. And so that's pretty much how we've widely accepted 50% as the partial tear. And usually in the OR, you just eyeball it. Sometimes you can measure it, but you're in the OR and it's almost completely torn. I think it's pretty clear, but use your discretion. Sanam, for diagnosis, what maneuvers do you perform to differentiate FDP from FDS injury?
So to test the flexor digitorum superficialis or FDS tendons, you ask the patient to flex the fingers voluntarily while the examiner holds the MCP and IP joints of the uninvolved fingers in full extension. For the FDP, you ask the patient to flex just the DIP joint while holding the PIP joint on that same finger in full extension. Now, Brian, what are some important considerations for flexor tendon repairs?
So many considerations. Everything has changed. Not everything, but a lot has changed in the last couple of decades. For flexor tendon repairs, suture caliber has actually shown to increase the force in static testing and fatigue strength in dynamic testing. So what does that mean? Basically, use of a 3-0 compared to a 4-0 is 2 to 3 times stronger. And in terms of number of strand repair, at least 4 or 6 strand technique is needed for repair, and anything less is going to be not as strong. Placement of the suture dorsally on the repair has been shown to increase the strength of the repair by 2 to 4 times, and it also decreases interference with synovial fluid. Another important factor is locking versus grasping. Locking sutures improve force and gap resistance compared with grasping loops in flexor tendon repairs. Some other things to keep in mind is when you're in the OR to perform an extension and flexion test, to make sure there's no gapping between the tendons, and also to make sure there's excursion and that the tendons glide smoothly. The patients under general anesthesia, you can do this passively, but if you're doing this awake, you can have the patient actually cooperate and have them actively flex and extend their fingers, which is actually a little bit more helpful. Nowadays, there's more surgery being done wide awake, so that this is more common. Specifically, wide awake local anesthesia, no tourniquet, also known as WALANT, makes the extension flexion test a little bit easier if the patient can cooperate with you. Another thing that is important to consider is the venting of the pulleys, which was once historically considered to be not a good thing to do. Now it's generally accepted that you can vent at the A2 and or A4 in order to promote adequate gliding. You can completely vent A4 and you can vent up to half of A2. It's not recommended to vent A2 completely since it's so broad. You want to make sure you have A2 to prevent the bowstringing, but you rarely need to completely vent the A2. And unless you have a very proximal laceration that's just distal to the A2, then there's going to be minimal excursion that's going to require you to vent the A2 pulley completely. And even if you do, you can technically do a reconstruction with a tendon graft, but that's going a little bit into the weeds here. In terms of post-op rehab, there's a little bit of a paradigm shift. It used to be thought that immobilization was the way to go, but now we know that early rehab is important. And the goal with early rehab is to decrease adhesions to improve tendon excursion and gliding. And then in terms of rehab, there's the question of passive versus active range of motion. So Trumbull and colleagues studied passive and active range of motion head to head. And they found that while active range of motion exercises led to better final range of motion, it came at a cost with a higher risk of rupture. And this kind of makes sense. If you're stressing the tendon that you just repaired, you're going to have more gliding, less adhesions, but you're also stressing the tendons. So it's kind of a balance. The literature showed a reoperation rate of 6% after flexor tendon repair and an adhesion rate of 4%. Sometimes patients will have stiff fingers after surgery, and even with hand therapy, the range of motion is not great. The key is to continue occupational therapy and hand therapy for about 6 months before you consider reoperation. Tenolysis is technically demanding, and all patients must be counseled preoperatively that complications like neurovascular injury or injuries to the pulley system and tendon rupture are all possible outcomes. Let's talk about some specific types of flexor injuries, starting with zone 1. Sanam, what's jersey finger?
So that's rupture of the flexor digitorum profundus, or FDP tendon, from its distal attachment. The jersey finger occurs when a flexed DIP joint is suddenly and forcefully hyperextended, leading to rupture of the FDP tendon at its insertion on the distal phalanx. So basically, these patients can't flex their finger, and the DIP joint is in a permanent extended position. And I'm going to leave it up to you guys' imagination to figure out where the name jersey finger came from. FDP injuries can be classified based upon the degree of tendon retraction as described in Leddy and Packer's grading scheme. And there's 4 types. The first type is injuries involving retraction of the FDP tendon all the way to the palm. And there's associated injuries to the vincula longus and brevis, basically the vascular supply of that tendon. So the injuries to the vincula disrupt the blood supply to that tendon, and they necessitate surgical repair within 7 days because you want to avoid necrosis of the tendon and permanent contracture deformity. Whereas in type 2 injuries, the retraction of the tendon is just to the PIPJ. The tendon stump is held in place by the vincula longus, which are usually intact. You can potentially have an avulsion fracture sometimes occur with type 2 injuries, and often the tendon becomes trapped in the A2 pulley. Without an observable bony fragment on X-ray study, it is impossible to determine the degree of retraction. Therefore, all type 2 injuries should be surgically repaired within 7 days. Then you have a type 3 injury, which involves a large avulsion fragment that is often intra-articular. The bony fragment prevents retraction past the A4 pulley and holds the tendon in near its anatomic position, obviating the need for urgent repair. Type 3 injuries are amenable to repair within about 2 to 3 months. As you can imagine, they have their blood supply completely intact. With type 4 injuries, they're basically a type 3 lesion with an addition of an avulsion of the FDP tendon from the fracture fragment. So in type 4 injuries, which are really rare, they require urgent repair because of the disruption to the tendon's blood supply again, because it's being completely avulsed off the bone. Now for my favorite topic, for all you skiers out there. Brian, what's skier's thumb?
I don't know. I wouldn't know. I don't ski. I'm just kidding. Skier's thumb is injury to the ulnar collateral ligament of the thumb at the MCP joint. Typically, ulnar collateral ligament tear can present with pain, weak thumb pinch, and instability of the thumb during abduction. This can be treated with 4 weeks of immobilization if the injury is not bad, meaning there's limited instability, less than 30 to 35 degrees under load, or less than 10 to 15 degree difference from the contralateral ulnar collateral ligament under load. Treatment depends on presentation. So for example, if it is incomplete or mildly symptomatic with minimal laxity, OT might be a good first step to strengthen the adduct muscles that stabilize the forces across the MCP joint. If the injury is more severe, meaning it's a complete rupture, or if it's chronic, operative intervention is warranted. If the injury is acute, direct repair may be feasible. However, if the injury occurred more than 4 to 6 weeks prior, reconstruction using a tendon graft using palmaris or plantaris placed through bone tunnels and secured with screws, periosseal sutures, or bone anchors might be needed. All right, well, I think that's about it for hand tendons. Like was mentioned earlier, hand is a big topic, and the in-service can ask endless questions. And it's usually about anatomy because there's just so much of it. So hope you think this was helpful. Sanam, is there anything you want to add?
No, I think we basically got everybody in the loop now.
All right. Well, if you like our podcast, spread the word, tell a friend, like us on Facebook, and follow us on Instagram at The Loop Podcast to get in the loop.
Bye.